So, when I was asked to talk about bone health, I thought, how do we put this in the context of for everyone? And in fact, we're not the only ones interested in bone disease. So is NASA. So I don't know how many of you saw The Martian. So, well, everyone's busy. Very few people go to the movies here. Well, if you haven't seen The Martian, I'll tell you, it takes them 3 years to get to Mars. So why is that important? Well, it's important. Why is NASA interested in bone disease? Because, in fact, gravity is not your friend when it becomes to bones. So, actually, anti-gravity. So gravity is your friend here. So all of us, we walk every day. We get microfractures in our bones. So our bones are in a constant state of turnover. And, in fact, every 2 years, our skeletal turns over. So our osteoblasts are forming bone. Our osteoclasts are breaking down bone. So it's very important when you go into space, you remove gravity, so you remove the sort of load-bearing stimuli in your body, and in fact, you lose bone. And if they've studied astronauts lose bone at a rate of 1% per month. So if you can imagine, Matt Damon, it takes him 3 years to get to Mars. He's going to need a walker by the time he gets there. So, NASA, in fact, is very much kind of in tune with us. And they're doing the same kind of studies that we've done, just on obviously fewer numbers of patients. So they're looking at the use of bisphosphonates, and this is one of their astronauts in a trial using bisphosphonates to prevent bone loss. So I would imagine they're going to be right in step with us with some of the newer agents as well that I tell you about. So, as I said, NASA's doing it in a few astronauts. Obviously, we have a lot more myeloma patients than we do astronauts out there. So even though myeloma is not as common as sort of the big guys, your breast and prostate, unfortunately, we're stuck with the fact that a lot of myeloma patients get bone disease. And those bone disease causes a lot of problems for them. Obviously, pathologic fractures, cord compression, hypercalcemia being some of the things that we worry about the most. So why is that, and what is so special about myeloma bone disease? Well, it's special because it's not just intrinsic from myeloma cells, but also the stromal cells clearly play a role in regards to our activation of osteoclasts. And what's very different from myeloma bone disease compared to other cancers is the disease in myeloma bone disease is purely lytic. So we stimulate osteoclasts and we inhibit osteoblasts. And so part of our charge is in how do we change that sort of dynamic. And the dynamic's controlled by multiple factors. So some of the ones I'm going to talk to you about today because of the drugs available are IL-3, rank ligand, and DKK1, and activin A. And all of these have now agents that we're studying that for use in this. Now, rank ligand first. Let's start with that one. Rank ligand stimulates osteoclasts and binds to rank. Rank ligand can be bound by osteoprogerin and so take away its effects on the osteoclasts. However, myeloma cells are sneaky, and they, in fact, increase your rank ligand in the body, so you increase your turnover of osteoclasts, but they decrease osteoprogerin. So you've kind of stopped that, you've taken away the stop sign for the rank ligand. And you see that sort of in this imbalance then in patients with myeloma. They have less osteoprogerin, and they have more rank ligand. And, in fact, that can be prognostic. And if you look at the ratio of rank ligand to osteoprogerin, patients who have a lot of rank ligand compared to the osteoprogerin have much poorer survival. And that probably obviously reflects the degree of myeloma they have in their body, or possibly also their response to myeloma treatment. Now, how do we currently manage bone disease? Certainly, we sort of use an array of things. We consult our orthopedic surgeons for patients where we're worried about fracture risk. We consult our radiation oncologists in regards to patients with cord compression. And obviously, we'll talk a little bit more about bisphosphonates, as well as some of the novel therapies. So let's start in regards to first sort of mechanical things that we do for our patients with myeloma bone disease. So one of the ones that we commonly do, since many of these patients present with compression fractures, is either vertebroplasty or kyphoplasty. We've had, and I think this sort of varies center to center. We tend to, at City of Hope, do a lot more kyphoplasty than we do vertebroplasty. And the difference is kyphoplasty is basically cementing the vertebrae. Kyphoplasty, you introduce a balloon here, and you blow it up, so you're sort of also expanding the vertebrae before you inject a cemented compound. There's been one randomized trial of kyphoplasty, about 130 patients. It was published in The Lancet many years ago, compared to supportive care, and it did show that kyphoplasty improved pain scores and quality of life in patients compared to supportive care. There have been 7 meta-analyses of very small trials also suggesting the same thing. So it does remain sort of a measure that we do for our patients. But ultimately, really, our optimal therapy for bone disease needs to target a couple things. We need to target, obviously, the myeloma cell. We also need to sort of reverse that axis we've seen, so stop this stimulation of our osteoclasts. And even more importantly, and this is really where the future is, we also need to increase new bone formation by stimulating osteoblasts. So let's start with bisphosphonates, because these have sort of been the tried and true therapy now for many years. And, I guess for many of you out there in the audience, this is something we take for granted, and myself included. But I can tell you, I was at a talk with Dr. Rudman, who's sort of the guru of myeloma bone disease, and he, at the talk last week in Seattle, made the point that before we had bisphosphonates, when you saw myeloma patients, they were in fact coming into the hospital every week, every month with serious fractures. And that's something that we see less and less now, fortunately. And in part, we see it less because of bisphosphonates. So the NCCN guidelines recommend that we initiate bisphosphonates in anyone who we're going to initiate myeloma therapy, regardless of whether or not they have lytic lesions. Now, what bisphosphonates do we use? So we've been in trials looking at both zoledronic acid as well as pamidronate, really demonstrating equal efficacy. We've tended certainly to switch to zoledronic acid really because of the infusion time, 15 minutes versus an hour to 2 hours using pamidronate. Having said that, though, in patients who have more renal impairment, we do tend to use pamidronate. Now, the other sort of intriguing thing about zoledronic acid was its effects on myeloma itself. So the bisphosphonates are directly apoptotic to osteoclasts. They also inhibit osteoclast maturation, but in fact, they may also have some direct anti-myelomatous effects. So this was the MRC9 trial that got a lot of press. In this trial, patients had newly diagnosed myeloma. They were treated either with intensive therapies, that's a stem cell transplant arm, or non-intensive chemotherapy, and they were randomized to zoledronic acid or clodronate, which is an oral bisphosphonate that's not available in the US. And this was the intriguing part of this trial. On multivariate analysis, so separating out everything else and looking at just the bisphosphonate use, in fact, patients who got zoledronic acid had about a 5-month improvement in their overall survival, raising the intriguing question, was this in part driven by the anti-myeloma effects of the zoledronic acid? Now, obviously, there is no free lunch, and obviously this becomes the question then of what are the problems when we do use bisphosphonates. And certainly in the MRC9 trial, they saw that 4% of patients developed osteonecrosis of the jaw. We also know now from a lot of retrospective studies that some of our risks of osteonecrosis may be related to duration of therapy. So there have been multiple sort of guideline recommendations in terms of trying to abrogate the length of time that we use bisphosphonates. Overall, various studies have suggested between a 6 to 11% incidence of osteonecrosis of the jaw. So the NCCN guidelines recommend that before you start bisphosphonates on anyone, that they get a dental exam. They also recommend that, so the International Myeloma Working Group guidelines recommend if you're going to do invasive dental work on a patient, so that's dental extractions, implants, that you hold bisphosphonates for 3 months prior to the procedure and also 3 months after the procedure. You don't have to hold bisphosphonates for teeth cleaning or root canal. Now, let's talk a little bit about osteoprotogerin, or OPG. So I mentioned that rank ligand binds osteoprotogerin. And so in one way, then it turns off our stimulus to the osteoclasts. So what if we have our own, and you look at myeloma cells compared to normal cells, you can see that myeloma cells have less osteoprogerin and more rank ligand. Now, you may have heard of a compound called denosumab. So this is a monoclonal antibody that's sort of doing what osteoprogerin does. It binds the rank ligand and thereby indirectly inhibiting formation and activity of the osteoclasts. And we have trials of it in myeloma. There's been a randomized double-blinded study looking at denosumab versus zoledronic acid in patients who have advanced cancers. This included myeloma as a subgroup of these patients. We demonstrated non-inferiority compared to zoledronic acid in terms of skeletal-related events. And we saw similar survival for all patients. But, and here's the big but, is that for patients with myeloma, in this subgroup analysis, we saw, in fact, an inferior survival with the denosumab. Now, you can argue that this trial was not designed to answer that question, and so the groups were not particularly balanced. For example, patients in the denosumab arm had more impaired renal function, so presumably perhaps more advanced myeloma. Patients in the zoledronic acid arm, you can see here, more of them had stem cell transplants, so perhaps those were more younger patients or more fit patients. So in fact, there's been another trial completed now recently. We're waiting for the readout looking just at myeloma patients with denosumab versus zoledronic acid. And so we're really awaiting those results. Now, as I mentioned, the other big thing that myeloma cells do, and they're very tricky because they stimulate the osteoclasts, so they sort of arm the enemy, and then they also disarm the friends, so they inhibit osteoblasts. And they do that by a variety of inhibitors, so DKK1 being important, sclerostin being important, and activin A being important. So can we target these things? Because ultimately our goal is not just to prevent bone resorption, but really is we want to build new bone in these patients. And you've probably heard it. Your patients come into you and you show them their skeletal survey, which is multiple lytic lesions, and then you treat their myeloma and they say, well, is my bones, are they going to go back to normal? And so how can we build new bone? So let's talk about the DKK1 pathway here. So DKK1 is an inhibitor of the wingless signaling pathway, which is a very important pathway for osteoblast differentiation. So you need the signaling pathway for your osteoblasts to differentiate. If you inhibit it, therefore, you basically inhibit osteoblast differentiation and activity. And in fact, we have data from patients with myeloma that patients who have high levels of DKK1 tend to have more lytic bone disease. And now, in fact, if you do gene expression profiling and think about your own myeloma patients, you see some myeloma patients are riddled with bone disease, but have no kidney disease. You see other myeloma patients who have, are on dialysis, but they have no bone disease. So in fact, if we do more genetic profiling of these patients, we are able to see differences of DKK1 expression in various myeloma patients, and likely explaining why we see differential patterns of bone disease in these patients. So, but if we inhibit DKK1, then our osteoblasts should be able to work more and build more bone. And certainly we do see that in mouse models here, that if we've given patients, some animal models, DKK1 inhibitors, we're able to grow bone. And so we have a couple trials ongoing looking at that in patients. They've been one completed, a phase 1 dose-finding study, giving it in combination with zoledronic acid, because as I've mentioned, the DKK1 inhibitor helps osteoblasts build bone, but we also still want to also prevent bone breakdown, so we give it with the zoledronic acid. This is another phase 2 trial completed also in patients with high-risk smoldering myeloma. The challenge with these trials is obviously waiting for a readout is also difficult, because markers in terms of measuring actual bone growth and radiographically can take years. So really what we look at for endpoints in these trials tends to be more markers of bone resorption as a measure of efficacy. And let's talk now about another drug that's sort of on the horizon. You actually heard about it this morning, and it's a drug that's an activin A receptor antagonist. So activin A stimulates your osteoclasts, and it also inhibits your osteoblasts. Now, how is that done? That's done through IL-3, which is secreted by the stromal cells surrounding the myeloma cells. So indirectly, the IL-3 is upregulated, leading to more activin A in your body, and leading to more osteoclast stimulation and osteoblast inhibition. And you can see this here by IL-3 treatment of myeloma cells. There's a huge increase in activin A in myeloma cell models. Now, if you block that, and you heard about this drug this morning by Dr. Greenberg, ACE11, sotatercept, is a activin A receptor antagonist. So myeloma doctors are interested in it in part because of its effects in hemoglobin, but even more because of its effects in bone and stimulating osteoblasts. And you can see it here again in an animal model, a vehicle-treated animal versus an animal getting ACE11, and you can see much more bone growth. So studies are also undergoing away in patients with myeloma looking at this agent. And then obviously the other thing we want to do is ultimately get to the root cause and treat our myeloma cells. And so certainly we do that with these agents. I don't even call them novel agents now. If you think about bortezomib, it's been around over a decade now. But the nice thing about these agents is they certainly have obviously direct anti-myeloma effects, but they also uniquely also have effects on osteoblasts. So, for example, bortezomib can induce osteoblast differentiation. So, again, our ultimate goal of helping to grow bone. We've also seen this in carfilzomib as well. And you can just see this here sort of more graphically. A patient who didn't respond, a lot of myeloma still in their body. And on the other hand, a myeloma responder here, and you look at their bone too, and we see new bone formation, which is, again, our ultimate plan for these patients. So to sum it up, we have multiple now approaches as our understanding of myeloma bone disease grows. We certainly have, I didn't put it in this list because it's not a novel anymore, are bisphosphonates, a mainstay of therapy. But really in the future, we're going to look at these other agents in terms of rank ligand inhibitors, denosumab. We're going to look at activin A antagonists, ACE11. And I didn't mention here, but sclerostin, also another inhibitor of osteoblasts. And we have anti-sclerostin agents under study as well. So ultimately, I think in the future, we're going to see a combination of the use of bisphosphonates plus one or more of these agents as part of the supportive care of our myeloma patients. So in summary, bone disease continues to be a major cause of morbidity in our patients. And I can tell you this just indirectly. From City of Hope has a new electronic medical record, so we have to sign off pain plans on every single one of our patients. So the head of the EMR came to me and he said, Dr. Christian, you have the highest number of unsigned pain plans of any doctor in the medical group. And that's because I have the highest number of myeloma patients. So, clearly this is a huge issue for our patients with myeloma. The median survival for a patient with standard risk myeloma is now 10 years. So clearly it behooves us also that we want those 10 years to be 10 years, not with the morbidity of bone disease as well. And so, as I mentioned before, we're getting smarter about understanding the pathophysiology of myeloma bone disease, allowing us to be better in terms of targeted therapy. Right now, what can you do? You can give patients bisphosphonates, and I didn't get into here, but the controversy, because there's really no good trial looking at how long you give bisphosphonates for. I generally give them for 2 years. The IMWG guidelines are 1 to 2 years, and then stop if patients are on remission, and then resume them if patients relapse. Certainly, we give patients vitamin D. And the other thing, very important too, is an easy thing to do, recommend weight-bearing exercise. And also, obviously, novel agents targeting myeloma, we use those as standard approaches for these patients. And even more of the novel agents as we move forward too, we hope that we can also improve in terms of our myeloma bone growth. And then I just wanted to acknowledge Dr. Rudman and Dr. Raja, who were very kind to provide me a lot of the slides today and who have really done a lot of the work in myeloma bone disease. Thank you. And I didn't get the stop sign today.